Good afternoon, everyone. Thank you so much for joining us. This is our Public Health Plus series. As many of you are aware, public health touches nearly every aspect of our world, especially now during a pandemic. And this series is really was envisioned to be a series of conversations that examines the space where public health intersects with several other disciplines. And our goal through this series is to really highlight those intersections and discuss how their work can broaden our thinking in the way of public health or whatever industry we're currently working in. The series was actually created by our Career Development Committee of the Rollins Alumni Board, of which Megan Kennedy is a member. And we are just thrilled to kick off this year's series today with Public Health Plus messaging. We are thrilled to have Dr. Marsha Vanderford and Megan Kennedy leading our session today. Megan is a Rollins alumna and a member of our Rollins Alumni Board. She is also the founder of Orange Sparkleball, which is an innovation and impact consultancy that accelerates initiatives in the private and public sector, as well as working with startups. I won't read her entire bio, but let me just tell you, she is amazing and we love her and we are just thrilled and honored to have her working with us and facilitating today's conversation. Martha is a health communications strategist and an expert in emergency risk communication. Her recent work has focused on the COVID pandemic with preparedness and human and animal health interfaces. She has a wealth of experience and knowledge. She has worked with WHO. She has worked with the CDC. She has just done amazing things all over the globe. And I won't spend a whole lot of time because I want to get to the content talking about her many, many accolades. But trust me when I say she is a rock star and we are thrilled to have her here today to share her expertise with us. So with that, ladies, thank you so much. I appreciate your time today and your willingness to share your experiences and knowledge with us. Megan, take it away.
Thank you very much, Michelle. That was super sweet. And Marcia, thank you for being here. We have had several conversations, and Marcia was just teasing me a little bit about we have had fantastic conversations, but have not done as much prep as maybe we should have because we got carried away talking. So we'll probably do that again now. But we do have some stuff planned. So Marcia, you have a great background that is endlessly fascinating. And the Public Health Plus series is about how public health intersects with other disciplines. And I think your career, the start of your career in particular, is the perfect illustration of that. Can you kind of talk us through how you got to where you are right now and how planful it was, or not planful?
I think not planful would be the best way to characterize it. But Megan, of course, you're quite right. I started my career as a faculty member, an assistant professor at the University of South Florida in the Department of Communication. And my area of study was really persuasion and argumentation in the political arena. I was really studying language. How do we use language to motivate people to work on behalf of social movements or political movements and so forth. And in particular, one of my very first projects was looking at how pro-life and pro-choice groups, really early groups in Minnesota, motivated their believers using language and symbols and so forth to get on board and to work at the Capitol and to march and protest and so forth. And so that was the beginning of my career. It was really studying language to see how it motivated people and how it created and shaped them. Just by happenstance, a colleague asked me at one point to look at some transcripts of some interviews that had been done in the medical school with HIV patients and their physicians, because there was some tension between them. And they were trying to figure out whether or not in some ethics training that they had given to the doctors to try to deal with this tension and to see if they could kind of help the doctors and help the patients have better relationships. So they had tried to do surveys and stuff before and after this training and had come up with nothing in the way of impact. So they just gave me these transcripts of interviews they'd done, and I applied the same kind of language analysis that I would to a political speech or you know, in-house rhetoric, if you will, to see if I could see anything in these transcripts that would help them. And indeed, we found all sorts of interesting things in the language used to describe patients' experience with doctors and doctors' experience with patients. And so I started working more in the health arena, which led to an opportunity to teach in the medical school. So for a while, I taught doctor-patient communication at to medical students. And then as a result of that, I was invited to CDC to jumpstart a campaign where doctors were the audience for the campaign. So I was invited for 6 months to jumpstart that. And I just never left CDC. And for 15 years, I stayed at CDC. And then I was hired at WHO to lead the communication team there. And so things just happened along the way. So I don't know that anybody could have planned that. I certainly didn't, but I certainly have enjoyed it. And you know, it's been a great career, and it continues to be. I still get to do work. The best part is that I don't have to do any administrative work now.
For sure. I'm going to jump back to the political rhetoric,
Yeah.
you starting in political rhetoric. And what was it about your approach? So you were doing political rhetoric and thinking about how people were using language to motivate political action. And what was it about that approach that allowed you to capture something different in those conversations between the physicians and the patients that they had been unable to capture with, you know, standard survey data? Like, as somebody who has a public health background, I would think right away to do a survey there. So what was unique about your political rhetoric approach that pushed that thinking forward?
Yeah, I think what I received from the study group were 2 sets of transcripts. Transcripts done of interviews of the physicians and of the HIV, the patients who were living with HIV, both before the ethics training that the medical school conducted and then after. And what they asked people to do in these interviews was to talk about their relationship with their doctor or their patient, what those experiences were like, how they felt about it, how they felt about how they were treated. And of course, this was in the mid to late 80s. Things were still pretty tense then. And so people told stories. The doctors told stories about what had happened to them with encounters with patients, and the patients told about their experiences. And a lot of times what you can tell in stories is people's values. Things are good, or they're described in a good way because they affirm values, or they affirm their sense of self, or they affirm the way they think the world should be. And what you also see is violation of values and emotion if those values get violated. And so what I did was read through and kind of create a framework that I called value analysis in narrative discourse, which is a fancy name for saying, how do you find values in stories? And then as a result of looking at patterns and seeing how people use language to shape these stories, what I found was that the patients and the doctors at the beginning, before this ethics training, were working on really different sets of values. For example, they often had energy around the same value, but in different directions. So the doctors had a real value on controlling their time. They really wanted to be able to get in and get out and get on with their schedule and balance their lives and have some time with their kids. And what they were finding, and what I found in their stories, was these patients took lots of time. They took lots of their time. And so there was a lot of struggle for the physicians in trying to contain the amount of time that was needed. On the other hand, the patients also had a lot of energy around time, but what they wanted was more time to engage with their physician, more time to talk about what was going on, more information about what was happening. So same value, time, but very different desires for how to use it. This is and so there were a set number of values like that kind of arose from the stories, where you could see where the areas of conflict were. And then after the interviews that occurred after the training showed a lot more value congruence. They clearly had gotten to some of the issues that were at odds for the two. So that's what I did with that project. And it was it was the application of something I think that had not been done before. It turned out to be a fascinating study, and told us a lot about ways to listen to people's stories as part of health communication.
I find that story fascinating because, is my audio okay? Okay, good. Okay, thank you. I find that story fascinating because as we get into your stories later on in your career, I see the same sort of reflection of understanding the values of a group that maybe has a different perspective than the public health practitioners. It's a theme that we'll hear frequently, I think, and I really appreciate about the way that you think about things. I do want to also touch just a little bit on something you touched on, which was the serendipity of your career. And another thing I loved was the what I would call just sort of an adventurous, like, willingness to try things. So can you just touch a little bit on how you ended up at CDC, and then the fact that you ended up there for 15 years is great. But I just love the story about how you even came to be at CDC.
Oh, well, yeah, I think one of the things I always loved in teaching at USF was the opportunity to apply things to practical problems, and to make students do that as well. One of the exercises I did, I taught an undergraduate class in health communication, we talked about, sort of empathy and that, of course, part of the teaching of doctor-patient communication as well. And so one of the things that I did in that class was to rent a bunch of wheelchairs and put students in pairs and then send them off on campus to see how they were able to manage being on campus with a disability. And then to write about that experience. And so doing things with knowledge, right? It's not just, and I think that's much more part of all curriculum now. But it was kind of a new thing at the time to really get out there and make people do things and then reflect on them and then integrate what we know. So when the opportunity came to go to CDC, it was really a delicious opportunity to see if I could do what I had been teaching for, at that time, about 15 years. And so that was really something I couldn't resist. I think the story of how the invitation happened is just totally out of nowhere. I happened to be in Atlanta visiting a friend from Tampa, and so it was almost at the beginning of the school year. I was still on vacation, and a friend of mine, a colleague at University of Georgia, called me and knew about my work, and his wife worked at CDC, and they needed somebody to jumpstart this campaign directed at physicians. And so he called me and said, would you be interested in coming, and talking to my wife about this opportunity? And I said, you bet. I'm actually here close to CDC. And he said, well, could you get over there in about 15 minutes? And I said, sure. So I scrambled through all my vacation clothes to assemble something that looked, a little bit like interview clothes, and, managed to do something that wasn't totally ridiculous, and then drove to CDC, and 30 minutes later was talking about this campaign. And a week later was doing it. So
Amazing.
yeah, it's a totally, out of nowhere kind of thing that changed my life.
That's one of the things, as we were talking, that I feel like we have in common, the ability to be okay with having an opportunity, trying it out, and going with it really at a moment or 15 minutes notice. So I love that about that story. And then can you talk just a little bit about, you've worked at CDC and at WHO, and you've also been an independent contractor, so you're an independent contractor now. What have you liked about both of those things, and do you have any reflections on your CDC, WHO experiences?
Yeah, I have to start by saying that I absolutely loved working at CDC and at WHO. I was proud every day of my life to walk in those doors and to show my badge that I was a member of this organization. And by nature, I'm not a true believer type of person. So I'm not easily attached to causes myself, or one side or the other of an issue. But I really feel so glad and proud that I worked both for WHO and for CDC, because I think it's an honor to work with colleagues who are absolutely the best in the world at their jobs, at their science, at the specialty that they've chosen, and the amount of dedication, where they go, what they sacrifice, the good they do. And I think nowhere do we see that more than in global health. That what both of those agencies have done to improve the health of the world it's just heartwarming and amazing. So I love being part of both of those organizations. Having said that, being a consultant now, having gone through 20 years of work in public health, I think being an independent consultant has some real advantage. And one of those things is that you are unfettered by organizational, I don't want to say ideology, but it was like going to WHO after having been at CDC for 15, 16 years, and suddenly not being a US citizen anymore. I mean, in a sense of, I was not there to carry out the work of the US government. I was not a US government employee. Then I was an international civil servant, and I had to take off my US hat and instead think about sort of the agenda as it was comprised by almost 200 member states of the WHO. So it's a different headset. But then WHO has its own headset, and so there's a kind of set of constraints there that you must you have to stay within. Being a consultant, you don't have that, and so you can say with respect to governments or agencies that you are working for what you really think is the best thing. Now they can reject that, but in a sense it's kind of that that old trite saying, speaking truth to power, but it's really true. I mean, I can remember standing in a small meeting room a couple of years ago, right after I had retired from WHO, and saying something to a group of ministers of health or ministers of a government about something they needed to do to apologize. And it was not well received, and it's something I probably would not have said in my former roles, but it was what I thought was the right thing to do. And so being a consultant meant in a way that I didn't have any hat on, except my own knowledge and my own experience, and that is a terrific freedom.
It is lovely, isn't it? We talk, my colleagues and I talk a lot about what is our responsibility as a consultant, and that we feel like, as it seems like you do as well, that your responsibility is to be the one that will say the thing that other people in the room can't say because of whatever affiliation they have.
Yes.
Which sometimes you go out on a limb a little bit with, and maybe it's not as well received as it could be, but it is refreshing to be able to say things like that. Well, thank you for that. I wanted to just touch a little bit on, because when we do webinars, we always ask people what the sort of theoretical basis they approach their work from is. I didn't say that well, but what do you bring to your work, and how do you, is it still guided by political rhetoric training, or have you now sort of widened your approach to the work you do?
Wow. Yeah, I think I think there's really kind of two things there. One is I'm really still an academic at heart. And I think in public health communication, more and more, you're seeing more and more academic people entering that field around health communication campaigns and so forth. But there are also lots of practitioners who really have gained so much experience, not so much in academia, but a lot of people who came up from public health, from other areas that have learned communication as part of their experience. What I love about, and I think is consistent throughout my work, is that I always start with what the literature is, what the research says about interventions. But I tend to grab from lots of places. So even though there is a growing body of research around my specialty, which now has emerged as, I think, emergency risk communication, it draws from all sorts of disciplines, psychology, increasingly from behavioral science, from behavioral economics, from increasingly digital communication. And so I still get to learn all the time. I have up on my shelf on my office here, a pile of new folders of articles that I haven't read yet, that are all related in some way to some project that I'm doing. And a part of my day is kind of integrating this new stuff with my master documents, right? What do we know about behavior change in communication during an emergency? What do we know about risk perception? Well, there's new stuff coming out that's relevant. It may not say risk communication on it, but it's relevant. And so that's always been part of what I do. The other part of what I do is just, I love applying stuff. Let's try this. Let's see if this theory works here. Oh boy, what can we do with this thing on this problem? So I think part of my adventure, if you will, has been, it's fun to do something new with the skills that I have. So I'm always willing to try something where I feel like I have enough credentials or enough experience, but it's new. What's a new place, a new project where that can be applied to see if it works? So I think those two things probably are consistent throughout.
Well, and I love, as I talk to you, how you talk about weaving outside influences in, whatever those may be. So digital communications, health economists, that kind of thing, into kind of the standard literature, because things, I mean, now as we see, are changing so quickly. Having that as just sort of your approach to how you move forward seems like it's probably something we all should take a cue from. So it was nice to, as you were talking, for me to be reminded of, that's a really nice way to approach everything. I'm sensitive about time, and I really want to get into a couple of the stories you have that I just love. So I'm going to jump into, you told me a story about Hurricane Katrina, and one of the lessons you may have learned working on Hurricane Katrina. And I think that's as somebody who kind of grew up in public health, I saw pieces of this often, and I think this is one of my favorite stories of yours. So I'll just let you tell it, because it's fantastic.
Yeah. So a part of my role at CDC was to lead the emergency communication system and during public health emergencies. So kind of starting with Anthrax up through the British petroleum oil spill, H1N1, and Hurricane Katrina. Lots of foodborne outbreaks and lots of hurricanes. And so Hurricane Katrina, as everyone recalls, was just this mammoth response at the federal and local and national level. And there were lots and lots of agencies involved: EPA, FDA, CDC, everybody in between. And so part of the role of the emergency communication team is to get information out the door to help people protect themselves, right? And we did that through the state health departments and through press and through one-pagers that were on the website and all that. And one of the key things during Katrina, of course, was there was lots and lots of flooding, and water was decontaminated, and people needed to know if they didn't have bottled water, if they couldn't boil their water, how could they get some clean drinking water? So of course, one of the ways you can do that is you can decontaminate small amounts of drinking water with bleach, but you have to be very careful about how much bleach you use. So we were developing in the communication team this one-pager on how to decontaminate drinking water with bleach. As was true for all of the information that we were sending out, it had to be cleared across multiple agencies and multiple levels of the organization. So we wrote this, and we started with how much, 1/8 of a teaspoon of bleach per liter. And so we sent this to our technical people and to the different agencies, and we got lots of pushback saying, well, this is not very precise. People won't, I mean, if they don't have exactly an eighth of a teaspoon, they could over or under and so forth. So one of the agencies sent back the one pager to us and said, no, you should use milliliters. You should use the amount of milliliters. And the communicators are looking at each other going, who's going to know? Think about, one, would they know what our audience know what a milliliter is? And would they have the ability to measure a milliliter? So we wrote sort of our explanation, sent it back out, and it came back, still not cleared. And this time the proposition was, well, drops. You could put in 10 drops. And again, we looked at each other and said, okay, some people may have a dropper, but lots of people aren't going to have a dropper. So we sent it back out around again, and basically the end of the story was that we never cleared this document because the agencies could not agree, and the communicators and the technical people really struggled to balance sort of the principle of practicality against accuracy. And that's a constant line that communicators and technical experts have to walk. Information has to be accurate, but it also has to be actionable. And so this was something that after Katrina was over, because I don't think we ever cleared this document. Eventually we told people to look at the instructions on the package of bleach. But we didn't clear the measurements. Eventually, in peacetime, if you will, after the emergency, it did get worked out. And now, if you go on the CDC website, and you can find a thing that says, here are 3 ways to decontaminate. And one is by a teaspoon, an eighth of a teaspoon, one is by drops, and one is by milliliters. So, that was the compromise. But in the middle of Katrina, we never got that worked out. And there were so many moving pieces and so many clearance points. And that tension just never got resolved.
Kind of one of those reminders to get out of our own way.
We learned a lot about communicating in emergencies, in the middle of emergencies.
For sure. Well, and that leads to some conversations about what you can learn from the community. I think my big takeaway from that was really making sure that we know to get out of our own way. And then as I talk to you more about other studies, really understanding that the community probably could help us more often than not get out of our own way. So with that, and kind of this whole idea of taking outside information and incorporating it into public health, your story about anthrax, I think, is really important. It's an important lesson for us, and that understanding of being able to talk the public through changes, I think we're seeing happen right now, not often not turning out well because we haven't articulated in a way that makes it easy to understand. But I think your anthrax lesson is pretty profound. I would love you to tell that story as well.
Sure. So I suspect many people on the phone are on the line, maybe too young to remember this, but I think part of the story is probably well known, and that is that obviously in 2001, right after the attack on the World Trade Centers, there was a discovery of white powder in some envelopes that had been sent to, letters that had been sent to congressional offices in DC, and the CDC investigated those letters, and also they have been sent to some journalists, some newspaper offices, and they found that what was the white powder was anthrax, which is a deadly pathogen. And so CDC responded. And one of the actions they took was to prescribe an antibiotic to prevent the development of this disease in the people who had been in the room where the letters arrived. And the antibiotic that was prescribed was called ciprofloxacin. At that point in the investigation, nobody was thinking that that powder could be aerosolized. It was weaponized. It wasn't until a little while later that CDC scientists investigating realized that indeed what could happen with this was that if the powder got into the air, it could be breathed, and then it could infect the lungs of people and they could become ill, which led them to the conclusion that as these letters containing this powder were going through really powerful mail handling machines in downstream post offices, it could have been pulverized. I mean, those letters could have been pressurized and the anthrax unseen could have gotten into the air and postal workers could have breathed it. And so this was discovered and became very urgent over a weekend, a couple of weeks into the investigation. So on a Saturday, suddenly we were in a position in the communication office of clearing and distributing a health alert network notice saying to postal workers and the facilities where these letters would have gone through that they needed to be taking prophylactic antibiotic to prevent people who might have been in those rooms at the time the letters were going through and it could have been aerosolized from getting anthrax. Well, this was a very, very urgent message, and it was Saturday and people were sort of, you know, I mean, 2 weeks in, people were tired, and it was, you know, anthrax was a pretty big shift for CDC in lots of ways. So we were rushing this notice through, and I read it and cleared it, and it all looked scientifically accurate as I understood the situation. One of the things that I noticed in the notice was that instead of receiving ciprofloxacin, the postal workers would be receiving doxycycline, which is a different antibiotic. It was less expensive. There was more supply of it. But I also knew that a couple of days before this notice went out that it had been identified as one of the antibiotics that the strain of anthrax in the letters responded to. So all of that seemed kosher, and I walked the letter from expert to expert to expert on that night to get it cleared. And everybody did the thing that scientific organizations like CDC, what we do, which is look at the accuracy, look at the clarity and say, okay, this all looks right. By the time we sent this out, about 8:30 on Saturday night, everybody felt like, okay, we had urgently done this and gotten it done. And I went home. And the next morning, I came back to the office on Sunday morning, and my phone was ringing off the hook. And most of you can understand now why. Postal workers were really upset at the change in medication, that congressional people had received a more expensive medicine, ciprofloxacin, and why were they receiving this less expensive version of a kind of antibiotic? What we didn't understand at the time, although we soon learned, was that, of course, most of the congressional members who were part of the investigation and received these letters and their staff were white, and most of the postal workers, or many of them, were African Americans. And so there was also the perception there that there was a discrimination, that it was racial bias, that CDC didn't value the postal workers in the way that they valued Congress, which of course was not true, but that was the perception. And what we learned in that moment was, one, you can lose trust in a heartbeat. And the trust was badly damaged between CDC and the postal workers at that point, and it took a long time to repair it. And second, and this is something that I think the world has learned and taken to heart is that in an emergency, things change and recommendations change as we learn more. And when that happens, public health agencies have to issue new recommendations and new information. And the public needs to somehow have their expectations set that this will be the case, that when a change happens, it's not a mistake, it's because something has changed in the knowledge. But the public health agency needs to set that expectation, and when changes happen, the communication has to be clear about why. And we hadn't done that. So it was one of the very first big lessons I learned very early in my work in emergencies, and I have certainly never forgotten it.
That's it. Michelle just put it, that story sums up the shortfalls of some of the COVID communications, and that's why I think it's such a good, it's often easier to go back and look at things that have happened in the past because you have the ability to have a little bit of distance from them. But I totally agree. And also the thing about unintended consequences. So no one was trying to do anything bad in that story at all, but the unintended consequences of that were long lasting.
Absolutely.
Yeah,
absolutely. Sometimes we forget. I mean, scientists and scientific organizations take very seriously the accuracy and what we know about the science and whether or not what we're saying is true. But we also forget that messages have relational aspects. And those relationships often come in what is not said and the tone of what is said, in the power relationships that somehow are implicit in the message. You know, that is part of it, and that's not science. That's a little bit of art, a lot of psychology, and the recognition that communities are different based on their history and their experience. And you know, some communities don't have a lot of trust for health authorities based on past experience.
Absolutely. And I'm going to ask you about the Ebola, your Ebola experience, because I think that follows really nicely with both the power discussion as well as community context. I'm also conscious of time, so if people have comments or questions, just pop them in the chat and we'll weave them in as well. But learning from community and also being very aware of context as you're trying to deal with an emergency, I can't imagine how hard that is. And I think your experience with Ebola really is kind of an example of the public health community really recognizing something wasn't working and pivoting and finding a solution that was really a nice kind of working with the community solution. So it's a nice, I think, story to end on. Although I do also want you to touch a little bit on what you're thinking about right now.
Yeah, so let me kind of distinguish for a moment. I was deployed to Sierra Leone during Ebola, but this story is a much bigger story, and it's not exclusively mine. So it's really more an observation. When Ebola happened in West Africa, the biggest outbreak in Liberia and Guinea and Sierra Leone. When WHO and other international agencies engaged in the response, they approached the response in the way that typically we have partnered with ministries of health and with government, and then supported those governments in taking actions to help with an outbreak. So when WHO and other international agencies, including CDC, went into these countries to help and into communities where Ebola was circulating, initially they went in as outsiders into villages, into communities, into neighborhoods with their WHO vests and their clipboards and their jeeps and so forth, their official vehicles. And of course, people coming in protective gear to help people and talk to them about safe burials and caring for, not to care for your dead or dying because you could contaminate yourself, and please call the ambulance. I mean, all these instructions that were well-intentioned from the ministries, from the international organizations, basically telling people in villages and communities and neighborhoods what to do and what not to do. And I think probably all of you remember from the news that those communities pushed back in a significant way, that sometimes they didn't do what they were being asked. Things went underground, they resisted. In some cases, they became openly violent, rock throwing, health workers being attacked with machetes. I mean, really some very violent resistance. But I think what we learned over time was that the government itself was in these cases, external experts, the government itself, were not trusted. They were not trusted in part because these governments had been part of civil wars in these countries not too long in the past, where some atrocities were committed and other kinds of dealings that were kind of violations of faith between governments and their citizens. And so there was not a lot of identification between the people in these villages and the government itself. Instead, the loyalty and sense of trust existed within villages and communities with local organizations and leadership. And so over time, what WHO and others learned, and CDC as well, was you have to go in through the community, through the leadership of the community, getting permission to approach a community, getting their input and leadership on how to control infections, how to honor the dead within the culture, how to familiarize people with ambulances. I know in Sierra Leone, many people, there were like, I think in the whole country, there were 2 ambulances before Ebola happened. And all of a sudden, some ambulances running into your village with, alarms blaring and all that. Why wouldn't you be terrified? And then they picked up your loved one and took them away, and you never saw them again. So people were really frightened of these things. So over time, trying to say to a chief of a village or a traditional healer, how can we work with the community to reduce the likelihood of transmission here? And this turned into a practice which now is ubiquitous in public health. It is community engagement, participatory public health, in which the community is leading. They are identifying how quarantine or isolation can occur. They are providing the translations. They are the folks who are enrolling people in vaccine trials. And so you may be able to provide, as a public health expert, kind of the how does the disease work and how do we prevent it, but then it is in the hands of the community to say, okay, this is what will work here. And this has changed the way that public health works in emergencies. I just got off a call just before this one on some vaccine trials, and the group that I am involved in is called Community Engagement and Risk Communication. So risk communication is now the second half of what the primary intervention is for this group. So it's very interesting.
That is very interesting. And I love how you've sort of traced the learnings through different epidemics, and kind of the evolution of public health is community driven now, because even in my, my growing up in public health was in HIV, there was a kind of conflict inherent then between the community, so ACT UP pushing in, and there was with some of us, there was a little bit of like pulling back a little bit and being a little nervous about that. And now I feel like we've, as a public health community, gotten past that in many ways, which is refreshing. So we're pretty much out of time, but do you just want to touch a little on what you're working on now and what you're thinking about? Because I think it kind of nicely wraps up sort of you as a public health person.
Yeah, thanks for that opportunity, Megan. I think I want to touch on something new and something old, both of which are things I'm thinking about. One is that we're seeing something very, I think, exponentially new, if you will, with COVID. And that is, no surprise to anyone. It's just the exponential growth of misinformation that is being shared about COVID-19 on social media. We have always had rumors. Risk communication has always included finding out, what people believe, true and false, about the disease, and trying to help fix that, right? Fix it. But it has never been as pervasive and as widespread, crossing boundaries, crossing networks, as we see now. And WHO has developed a term for this. It's called an infodemic, which is the spread of misinformation through the channel or source of social media. And if you go on the WHO website, you will see a whole section on infodemiology where they've brought together experts from many, many different disciplines to try to better understand what is happening and how to address it. And it's a very exciting and very interesting area of work, and it brings together things we've known before, like the importance of belonging to groups, which is part of what drives people to share information online, and new things, like we can now map whole online communities and see where public health agencies overlap and don't overlap with the sharing of information on that. So it's a whole new world there, and it's fascinating, and I encourage you to take a look. The something old really has to do with the upcoming vaccination efforts. Obviously, they're underway now in trials, but assuming that we do have some effective and safe vaccines, we will soon be facing the same question of vaccine acceptance that we face with influenza every year, that we face with polio vaccination in the countries where polio remains, that we face with childhood routine immunization, which is so important to prevent preventable disease. But we also know that in this country and in Europe and in many other places of the world, vaccine hesitancy is an ongoing, chronic, and growing problem. And we have been working on this and worrying about it for a long time. And we're going to have to look at it, we're going to have to struggle with it again. And it's exacerbated, of course, during COVID, because people are even more hesitant when there are concerns about safety. And the message about this vaccine is, we're pushing it, pushing it, pushing it. It's going to be very fast, coming very soon. And people also saying, well, usually it takes years to do this. So the perception of those who have to make a decision about whether to take it and have their family members vaccinated, you know, there's vaccine hesitancy, and then there's the additional concern about how safe can this be? And, you know, we're going to have to hit very hard in areas to be transparent about the safety protocols, about the decision making, and so forth. So it's an old problem, but it's going to be newly important if we're ever going to be able to socially engage while this virus is still circulating.
Well, it seems like the old problem is being exacerbated by the new infodemiology that's happening as well. To increase the complexity.
Yeah, you're spot on.
Well, thank you so much. I love listening to your take on things, and you have an amazing kind of perspective on many epidemics and the evolution of our thinking around how you communicate around an epidemic. So I've loved to learn from you. So thank you.
Oh, thank you. It's been a pleasure and really fun. Some of these stories I haven't thought about for a long time.
Well, I have been happy to listen to them, and thank you for sharing them more broadly as well. And I think Diego's gonna, there he is.
If we have anyone who has a question in the audience, we'll be glad to answer it. Right now we have 13 participants, so we can go ahead and start the breakout room session. With the amount of people that are still left with us, we can do a first breakout session where we're gonna divide it in two groups. Megan will be in one and Dr. Marsha will be in the other one. Just for you guys to discuss anything related with our conversation today or public health in general. That will be good groups for sure. That after 15 minutes, I will bring back everybody to the main room, and then we can make a bigger conversation to share some of the insights that you guys have taken with your breakout rooms. So
I was just going to thank Marcia. Marcia, that was fantastic, and I really appreciate you talking to us.
It was fun. I really enjoyed it. And then I had fun in the breakout room learning what Danielle and Sophie and Ashley and Gail, you know, why they came to the session and what they're working on. I really was caught by something Sophie said about her work or her interest in homelessness and the frame that she's thinking about with her work, the difference between the answers that people come to, whether they approach homelessness from a systemic level or an individual level. And depending upon your frame, the answers that you come up with are quite different. And then the group as a whole, we went to COVID and wearing masks, and how, depending on if you think of this as if you're a collective consciousness or an individualist approach, how you come up with different reactions to why you should wear a mask. So, you know, framing is a really important part of helping people to come to conclusions that you're hoping they will come to, right? We're not going to get to mask wearing in mass with an individualist approach to this.
It's also that's fascinating to me. It's also interesting because it illuminates of perhaps why we're having such a hard time or such a kind of a visceral emotional reaction to if you are a mask wearer and you see people not wearing masks, or, you know, even if it's your family or your friends, because it really does come down to your belief system and how you kind of view the world. And so it does go to, I mean, I just had a little aha moment of, well, yeah, like, you know, because I hear people say, I just don't understand why people won't wear masks. Right? And it's not necessarily, I mean, it can be the messaging, but it can also just be your kind of internal thought process on how you view the world and how you view your place in it, I suppose.
That's right. Yeah. Well, and it's, you know, it's, go ahead, Megan. Yeah.
I was just going to say, in the last 2 days, I've had 2 conversations with people who have young children. And the children were totally fine with the idea of you wear a mask because you're helping everyone. So they went to the sort of systemic solution really quickly and easily. But then they were moms. Both moms were talking about they got very upset when they saw sort of that systemic, we want to help everyone break down. And it caused each of the children, one was like 4 and one was 6, to have like a real crisis in, I thought everyone wanted to help everyone. Like, we're doing this as a collective. And when each of the children saw that wasn't true universally, that caused, like, one of them was sobbing. So it was a really interesting having that same conversation 2 days in a row. And then the third day having this conversation has been interesting. So I wonder if it's not inherent, but it's learned, is where my mind went.
Sure.
I don't know.
Yeah, that's interesting. You know, my daughter goes to a small private school, and they have been in person progressively one more day each week over the last several weeks. So they're kind of building up. And she has dyslexia, so being face-to-face is very important for her. And of course, you know, before I agreed to send her back, I had my checklist of, you know, all the protocols that need to be followed in order for me to feel this comfortable with it.
Sure.
Because we knew we were taking on more of a risk. And she is now back at school 4 days a week. And of course, masks are required and social distancing is strictly enforced, and you know, and all those things. And that actually helped my daughter feel better about, you know, her own exposure. But just last week, they were outside for lunch, and several of the students in her grade were kind of gathering on one end of the outdoor area, and they took off their masks. And my daughter, I mean, she kind of lost it. And she really almost had a panic attack. And she came home and, of course, told me about this, and she was really upset by it. And we talked about it. And those same kind of things that I'm now realizing were what she was saying to me, is that she didn't understand why they weren't thinking of her. Because she's looking at it as, I wear my mask to protect you, which is what we've taught her and what we've said to her, you know, and she took that as, they don't care about me because they're not wearing their mask. And that's, I guess, again, another aha moment in this conversation that I've just had, that, you know, at the time I didn't interpret it as that. And we talked through the situation, but it makes perfect sense if the approach is, you know, an individual versus a collective kind of mindset of why she would have had such a strong, you know, reaction that they were harming her and they didn't care about her, and why she got so upset about that. Yeah. Interesting. Just sharing.
That was exactly what the one mom of the 4-year-old who like had a meltdown said was what the 4-year-old was upset about. Like, they didn't care about her family, which is really interesting and hard.
Hi, this is Ladies.
Ladies, it says Galaxy.
Sorry. Yeah, I am having bad connection issues, so I came to Dunkin' Donuts, but it's not much better here. It's too loud inside. So I did have a question for Marcia, though.
Yeah, go ahead.
I would love. Perfect.
Yeah. So I was wondering, Marcia, a lot of the examples that you talked about were emergency situations that require like really quick action. And I know a lot of what you spoke about too was just like that necessity of establishing trust in the community. And that was just so vital in some of the examples you used. how do you go about establishing that trust in emergency situations where everything is moving so fast? But it is really essential to like being effective.
Well, the good news is that trust is has a lot of components to it. And so you have a lot of resources. You think about it like one of those, I think about things pretty practically, I think. And so you think about a menu that has choose one from column A and one part of your meal from column B and one from column C. Trust has a lot of the same kinds of choices to it. So part of trust is based on past experience with your organization. So having already established a relationship, choosing spokespeople or people to lead community efforts who are already members of a community and have established relationships, that kind of choice can help establish trust. Other elements of trust include things like consistency. Are you sending out messages that are consistent over time and across all the levels of your organization and with other experts? Because the more people hear something, the more they believe it and the more they think that you are an expert. And part of trust is based on your perceived competence, right? Are you smart enough, capable enough, skilled enough to get this under control? So that's part of trust as well. Another part of trust is something you might call goodwill, right? Does the audience think you care about them? And you care about them more than you care about yourself. And so demonstrating that, what you're doing is for the good of the community, your family, your village, your group, and so forth, establishing that. Another part of trust is honesty. And so being consistently upfront and transparent about what you're doing, how you're making decisions, and so forth. So those are just some of the things that we know over time come together to create impressions of trust. And sometimes you have the opportunity in a community to use some of those, but not others. And sometimes you have a full plate of opportunities there that you can use. And sometimes you only have one. And you use what you can use. But the fortunate thing is that there are a lot of components that you can develop in order to establish and build trust. Of course, the best is when you have a previous trusted relationship with a community that's been established over time, and you're not trying to create it just by your messaging in the middle of an emergency.
Thank you.
I wanted
that was fantastic for all of us.
Yeah, that's great. Just a quick reminder, I dropped in the chat a link for a Typeform survey that we would love you guys to fill out for us. Your feedback is very valuable for us to keep bringing this series. Michelle, the link is out there. We know that some people drop off before the breakout session started or even the Q&A session started. So maybe we can include that one in the recap email for those who drop right before we split it. We have 3 more minutes. If anyone has any other comment, any other question, please feel free to do so. We are aware of time and we want to be respectful of the time. And I know people have meetings these days very frequently. So other than that, I think we appreciate every one of you guys for participating. It's been a great one. Dr. Marcia, thank you very much for joining us today on this. All your insights were incredible. A lot of great messaging, a lot of things to think about when we speak about public health and how to address the public and overcome even, internal things that happen in different organizations. So thank you so much for that. I have dropped Dr. Marsha Vanderford LinkedIn in the chat as well if you guys want to click it and know more about her work. you can do so there too. From my part and the Public Health Plus and the Emory Rolling Schools, I just have to say thank you everyone for participating, and I hope that we catch you on the next one.
Thanks to everyone.
Thank you very much.
Bye-bye.
Thank you, everyone. Have a great afternoon.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye.